Radiology primer for non-radiologists. I'm writing this to try to help anyone who's in training or beyond have a basic understanding of radiology studies. I feel like radiology bitches all the time about people ordering the wrong study, and we expect people who aren't radiologists to understand all the intricacies of what we do. That's obviously wrong. I can't take out a gallbladder, intubate a patient, or manage active heart failure. So I don't know why I should expect you to know the difference between a standard CT abdomen pelvis and a three-phase study. We're all on the same team, so I'd like to try and help. This was a post on Reddit, so I just wanted to take a quick look at it because it kind of piqued my interest. I actually saw this 28 days ago and hadn't had time to just take a look and read it, but now I'm getting around to it now. So radiographs, a great first-line imaging modality, truly excellent at looking at bones. Due to the physics of how it works, it's great if you're looking at soft tissues, also very good for line placement, obviously. So tips, NG tubes should course midline and then go below the diaphragm. If it veers left or right at the T6-ish level, you've put it in the airway. And this is actually a really good learning point that I learned in residency is ideally to assess NG tube placement, a chest x-ray is actually better than getting an abdominal x-ray. A lot of times we get the abdominal x-ray, and I've even tried to order a chest x-ray to assess NG tube placement before and had the nurses kind of tell me it was not allowed at this location and this was not part of protocol or something like that. But actually chest x-ray gives you a much better image because what you really want to see is it going all the way straight down, basically the whole chest, and then passing through the under the diaphragm. Now, if you get an abdominal x-ray, it's possible that it veered off up in the chest somewhere and then somehow got back to midline, so you could be fooled. Pretty rare, but definitely, a nice learning point in my opinion. ET tubes should be 2 to 5 centimeters from the carina. Honestly, everyone has their own preference. I usually say 3 to 5 centimeters when I'm teaching med students. Make sure it's below the clavicles and not in a main stem bronchus. If you can count ribs, the carina is usually at T6. Central lines, right side line should go straight down the SVC and right atrium, and the left-sided line should cross the midline on their way to the SVC. If you see a left-sided line remain on the left side, it may still be venous due to a duplicated SVC or an internal mammary vein. That sounds very rare. I've never seen this situation, but very interesting for sure. One of the other things you may see is when it's coming in from the left side, it may loop up basically the right brachiocephalic vein on that side. And so that could be another common issue with your central lines if you place them on the left side. So again, that's why we prefer to place the central lines on the right side, because it's more of a straight shot right to the heart and less chance for the line to get kinked or move in a weird direction. If you're concerned about pneumoperitoneum, make sure to get an upright radiograph. It moves up and may not be seen if the patient is supine. Very good learning point. CT is the donut of truth. It's good at most things with certain limitations. It functions using x-rays, but instead of one image, it does it in cross sections. My understanding is that just takes a whole bunch of x-rays, and so you can kind of scroll through and just get a much more defined resolution and really visualize where the structures are a lot better. One of the most common areas of confusion for non-radiologists is contrast, and I totally agree with that. I feel like that was one of the most difficult parts, and even now, sometimes I'm not sure whether I should get contrast or not. Contrast is something injected into the vascular system, which allows us to highlight certain portions of the vascular system based on what we want to look at. I like how this guy is writing things in very, very basic terms. I feel like it makes it very approachable, especially for interns, medical students, people who are really just learning about these things for the first time. So CTA is a CT angiograph. These are arterially phased studies. The technologist waits until the contrast is at a high concentration within the aorta, then triggers the study. In the abdomen and pelvis, this allows for evaluation of the aorta and the proximal portions of its branches. In the head and neck, this allows for assessment of the carotid and vertebral arteries of the neck and the intracranial arteries of the head. This is primarily used to assess for large vessel occlusion. So a lot of times when I'm getting contrast, it's going to be for CT PE, so to check for any PEs or any filling defects in the pulmonary vasculature. In the abdomen, a lot of times we need to get the contrast to assess better for infection. If we get a CT without contrast in the abdomen, it's not as effective at looking for infection there. And then, interestingly, in the chest, I believe you actually can get a non-contrast CT for looking for infection, because the air actually acts as its own kind of contrast to help better define infections that may be present. But yeah, CT angiographs, this can be timed for mesenteric evaluation in GI bleeds. Again, yeah, great. If you're putting contrast into the arterial system, if it's spurting out somewhere, you're going to see that on the CT scan. Standard CT scans are performed in the portal venous phase. Typically, this allows for roughly equivalent enhancement in the arterial and venous system. Okay, so this is what I was talking about earlier about my when I typically get contrast with my studies. CT scan for PEs is triggered when the contrast concentration is maximum at the main pulmonary artery. And the CT venogram is triggered when the majority of the contrast is in the venous system. Three-phase, this includes a non-contrast study, an arterial phase, and a venous delayed phase. So I'm curious about what this one is, because I believe this is probably for the liver, and it really helps you determine if somebody has hepatocellular carcinoma, because it lights up on the arterial phase, I believe, and washes out in the venous phase. Whereas if it's like a metastatic disease from somewhere else, then it's the opposite. Although I'd have to double check that. I have an Anki card about this. Acutely, this is really good for evaluating for bleed. You won't see anything on a non-con. And then you have to know what you're looking for and what a good scan is for. So CT brain, I feel like the post is getting a little bit kind of meandering here and kind of just like train of thought. I feel like he didn't really make a good point of like when you should get contrast or not here. I feel like that would be really helpful for a lot of people. CT brain non-contrast, if you already know this, I'm sorry. It seems like no one knows why we actually do these in stroke patients. These are not done to evaluate for stroke. These are done in the setting of clinical stroke to rule out bleed, so TPA can be administered. And yeah, I think this is a pretty common learning point early on that most people are familiar with, but I'm sure a lot of people sometimes don't truly understand the indication. It is not better than CT angio in almost any situation. At best, it's equivocal. People assume MRI is better. I actually heard that CT angio is better for actually getting the best look at vasculature, although this is only something I vaguely remember. Either way, I'm not ordering these studies very often at all, but either way, those are going to be looking for large vessel occlusion of your like carotids or even intracranial occlusions, the circle of Willis and things like that. If you have a soft tissue hematoma and you want to look for active bleeding, don't get an angio-only phase study. This almost certainly won't show it because it'll be too early. Get a normal phase study or do a multi-phase study with angio and delayed. This is another thing where I think this is definitely more of like a radiologist thing. I think, we would probably just order a CT scan with contrast or CT angio, and the protocol, the radiologist will protocol it to time the contrast the exact way that they want. So I think this is a little bit in the weeds as well. MRI, this machine is magic. Using the unholy powers of magnets and radio frequency pulses, MRI allows us to evaluate tissues based on a variety of characteristics. This is excellent for soft tissue evaluation, areas that are difficult to see on CT, brains, masses, etc. He's providing an example. A provider was concerned with a patient who had lost the sense of taste. They ordered a CTA of head and neck. This study will provide nothing. Loss of taste may be neurologic, but CTA evaluates brain parenchyma poorly and shows large vessel occlusions. And LVO is extremely unlikely to cause isolated loss of taste bilaterally. What the provider needed to order if they were concerned about cranial nerves or brain nuclei involved in taste was an MRI brain. But not any MRI brain. They need a small field of view with a particular sequence which highlights the cranial nerves. So again, know what you're looking for or else the MRI will be useless. This is something that, neurologists are going to be pretty familiar with when they're ordering their specific studies. The most common issue that I run into with MRIs is patients not being able to tolerate it, because when you go in for an MRI, it actually ends up being like 30 minutes to like 2 hours sometimes if you're getting like full CT or full MRI of the entire spine and like brain also. And people get very, very claustrophobic, and they also get very anxious. They can't hold still, which they really need to hold still in order to get a good quality MRI. So a lot of times we have to order anxiolytics for them. For example, 1 milligram of Ativan, and sometimes I order 1 milligram and then an additional milligram of Ativan if the nurse needs to give it while the patient is going down. So it's really important to ask a patient if they've ever had an MRI before, if they've ever had claustrophobia before, and if they are going to be able to tolerate this or not. It's also a big issue with patients who are requiring oxygen. Because if there's any sense that the patient's a little unstable, it's very difficult to obtain an MRI because, again, they have to be kind of in this less supervised environment and lying flat for a really long time. You may see patients with significant pulmonary edema for whatever reason. Maybe they have really bad heart failure. They also are not going to be able to tolerate the MRI unless you lie them down in the early morning and actually test to make sure that they can maintain their O2 saturation before they go down. Another thing for MRIs that is really important is looking into the pacemakers that they might have and if they're MRI compatible. The main way to actually confirm this is really to just look up the brand of their pacemaker and then go to the brand's website and then find the contact information there. And then you can just call this on-call representative basically, and they will tell you if it's MRI compatible, and if so, if they need specific MRI protocols to be done, they will write that all down for you, or they will tell the MRI technician and get that all sorted out for you. Usually there's like this big questionnaire of any metal pieces or fragments that are in the patient that you also need to fill out to make sure that they don't have anything else that could get disrupted by all the magnetic fields in the MRI. Nuclear medicine, let's talk about nuke med. This is a pretty new area of radiology where we use gamma emissions from a radioisotope to image. What we image depends on what pharmaceutical or molecule we tag the isotope to. For instance, in a tagged bleeding scan, we take the patient's red blood cells, tag them with something called technetium-99m, and then place the patient under the gamma camera. So HIDA-scan, this is what we use to assess for biliary tract and to see if there's any cholecystitis going on, or tagged red blood cell scan, again, used for bleeding. It's not super useful because if you can't see a bleed on CT angio, you won't be able to see it on angiography, which is what IR uses for embolization. So a tagged RBC scan will confirm active bleeding, but won't be able to help much beyond that if the bleed isn't evident on CTA. I didn't know that. VQ scan, this is useful if you're concerned for PE but don't want to give the patient contrast. You really need a chest x-ray or other chest imaging within 24 hours for accuracy. And you also, another big thing here is the patient really can't have baseline lung disease. If they have baseline lung disease, the VQ scan is just going to be off no matter what. At my institution, it's actually really rare that we get VQ scans, but when we were rotating at Kaiser, we would get it fairly often, actually. Not fairly often, but more frequently than at my institution. In general, I think its utility is kind of limited because A, it's a little difficult to obtain. B, even if you do get the result, it's always something like, okay, no possibility of PE, which is good, but then there's like low probability, intermediate probability, high probability. None of them are very definitive like a CT angio is. And then a lot of times, if it's low or medium probability, depending on your own clinical suspicion, you're going to have to end up getting a CT angio anyway. And so a lot of times we end up just getting the CT angio from the get-go because if they have a PE, you want to identify it right away. And then there's all the literature that is very plus or minus on whether contrast-induced nephrotoxicity is actually a thing. Like you'll talk to radiologists and they will all say that contrast-induced nephropathy is not a thing. Even if you talk to nephrologists, they say that the evidence is not strong for it, but then they see it all the time. And then when we do nephrology rotations, there's patients always having contrast-induced nephropathy. So I feel like anecdotally, we see it very, very often, which is a little weird. Sometimes, we don't know. Maybe we're just blaming the contrast, but it wasn't actually the cause. But yeah, based on the studies, it's actually not supposed to be as big of a thing as we, make it out to be. Brain death studies, radioisotope is injected into the venous system, then imaged for 2 minutes to see that it goes bilaterally into the common carotids. Static images are taken for a few minutes afterwards. In the setting of brain edema, like what happens in brain death, there is too much intracranial pressure for blood to get into the intracranial space. It's shunted to the external carotid artery. Seeing no radioisotope in the region of the brain is compatible with brain death. Please note it is compatible and not diagnosis. Brain death remains a clinical diagnosis in most all states. So that's actually interesting. I didn't know exactly how the mechanism worked with that one. I'd much rather spend a few minutes on the phone with a clinician figuring out what exact study they should order than spend a half hour reading an exam that can't answer their specific question, all the while finding a bunch of incidental nonsense and accepting all legal liability while doing meaningless work. Nice overview. I feel like some radiologists say this, but then other radiologists say, to heck with it. I'm just going to read it because they have such a huge pile of studies to read. So even though there's tons of studies that are ordered that are not really indicated or really not going to give the answer that the ordering person is actually looking for, they just end up reading it anyways because, calling the other person who ordered it, waiting and paging them, and then waiting and then discussing with them what best study would be instead. All of that takes so much time that I think most radiologists actually don't feel like this. They just end up reading everything that comes in. So let me know if you have a different experience or you've heard something else. Agree. The only thing worse in residency was when the techs called me for a completely incorrect study. Bonus points if outpatient for the insurance issues, and then I had to spend time trying to track down the clinician to get the correct exam ordered. Double bonus points if after business hours, so no one is at their clinic. All of this takes time and is so annoying for everyone. Just call and spend 2 minutes on the phone to prevent problems for you, me, and the patient. The problem with this is that the ordering physician is not going to know that they ordered the incorrect study. Sometimes they're going to be like, okay, I really don't know. Let me call radiology and just kind of get an idea. But most of the time when they order it, I don't think they realize that it was the wrong study. And what would really help is, I don't know, I feel like it would be useful if radiologists could just modify it and not have to have the ordering physician change it. If they put the correct indication and then the radiologist could say, well, okay, this would actually be a better study for this indication, then I feel like they should be given the liberty to modify that. But I think as it stands, they don't really have too much leeway with that unless it's like contrast or non-contrast. Great post. There are exactly 0 times I've ever talked to a radiologist about imaging or indications and not learned something. I always enjoy it and find it useful, especially coming to find you in your dark, hidden away rooms and talking face to face. It was drilled into me as a med student and only made more clear as a resident. Every imaging study you order is a consult to radiology. The indication/clinical information section is the consult question. As with consults, the better question you ask, the more helpful answer you get. You're my hero, Dr. Radiate says. I will say I really feel like it is really great to talk to radiologists because every time you talk to them, you do truly learn so much and they provide you a lot more information than they may have included in the report. My big hesitation with calling them all the time is because I feel like I know how busy they are. They're like slammed all the time. And to me, I feel like they take their time. Like if you call them, they will take their time to go through the study with you. And I really appreciate it every single time. But I just feel bad. I feel like, man, I'm wasting their time right now because they're not getting any compensation or any benefit other than, being a good Samaritan for taking the time to explain things to me. But I would say that, they're obviously you're helping the patient out too. And that's probably the most important thing. But in terms of their own workload, it's just slowing their workload down. So I feel like a lot of times I've had a high threshold for calling radiology. I've had a bit higher of a threshold for calling radiology than I probably should because I feel like I'm a little cognizant of how much they have to work and I feel like a little bit bad if I took away from their time. Also, please stop the redundant ordering of head neck MRAs after negative head neck CTAs. There's no effing point because the CTA is better. I'm just starting to take call as an R2 and find it quite satisfying when patients are crashing overnight. The team is frantic AF and I can help them select the right study. Example, last night, concerned for dissection, they ordered a chest non-CT, non-con because GFR was 59. Nah, bro, let's get you the right study. Yeah, so obviously in this case, they need the contrast CT. Even if this person's GFR was 20, if you're concerned for dissection, you have to order the CT scan with contrast to rule out dissection because aortic dissection can be immediately fatal. So even if their GFR is crap, you need to order the CT scan with contrast. If they can't determine the need of contrast to rule out a dissection, it makes me question what they actually do know and what kind of clinical care the patient is truly receiving. Yeah, I totally agree with this. And, if you're a PGY4, this is very obvious to you potentially, right? But you do have to realize, you're at a learning institution and people are learning and people are in the ED or they're interns on the floors and they don't know this stuff. So, it's part of what comes with being in an academic institution. Everybody has to learn at some point. People rarely visit the reading room anymore to ask clinical questions, almost always just older doctors. When I was a med student in 2016, it was routine to visit the reading room to go over stuff. Now maybe 4 to 5 people come in over a day. People could learn so much talking to us in person. Hey, I'm a surgery resident. I call you guys all the time. I usually look at scans as soon as they are done before the read is in, often because it's a sick patient and I'm trying to make decisions ASAP. My question for you is, how annoying is this? To be honest, we get burnt out by how often the phone rings. If you're going to disrupt the workflow on call to go over something, I think we are generally much more pleasant and congenial if you come to the reading room in person. Being the one person who we can put a face to the voice makes a big difference. And if something is weird and I have to run to by an attending, usually I just text them and page with whatever the attending says. I totally understand that and will keep that in mind. At my main hospital, I know where you all sit during the day, but at night, I don't know where the residents sit. Putting a person to a face is huge. It's so easy to get irate at a page and a phone call, but when it's a person, you realize they're just another doctor looking for some help. Yeah, I think maybe there is some, a lot of people don't like to go down to the radiology reading room because A, they don't know where it is, and B, they, don't want to walk down to the basement or wherever far away in the hospital the radiology reading room is. And maybe we should have a lower threshold for doing that because I think it improves patient care. It's fun. It's like fun. I liked taking my medical students and interns and stuff to the nephrology room and just like talking face to face with people. And so I definitely should have done that with radiology too. I feel like you learn so much, right? And so maybe we should start doing that more, even though in this day and age, it's all become about texting and tiger texting or secure chatting or whatever. And, calling people on the phone. Seeing somebody in person, you do learn a lot more, in my opinion. For me, it's never annoying. I love it. Yeah, it can interrupt the workflow, but it's part of the job. The radiologist you talked to was a dick. There's no other way around it. Tonight, I have time. Otherwise, I wouldn't do this. Seriously, what an asshole. Very true. Once in a blue moon, I've seen a medicine doc, but the few that more frequently come down are always surgeons. I feel like I complain a lot about the ED ordering incorrect studies or studies with garbage histories, but is the onus on radiology to properly educate? Honestly, don't know the answer. I feel like clinicians most commonly came down to the reading room during peds rotations. Not sure if it's due to the culture, but nearly every day there would be a giant rounding team that would gather near our attendings as they went over findings. Yeah, I don't think medicine people go down very often at all. It's not a typical culture for us to do that, but maybe it should be. Like I said, I think a lot of times medicine physicians are just always documenting all the time and spending so much time on documentation that they just don't feel like they have the time in their day to go down and talk to the radiologist. So this may be the situation where we need to really decrease and lessen the time that we're spending documenting so that we can do more interesting and engaging and also useful things for the patient, including talking to the radiologist directly. So yeah, maybe once my paternity leave is over and I go back to work, maybe I'll try and make a little habit change to seeing the radiologist a little more often. Try the ACR appropriateness criteria. This is a really great resource for knowing when the imaging study you are ordering is indicated or not. And yeah, that's pretty much it. I hope you guys enjoyed this little discussion. I thought this was an interesting read. I'm definitely looking forward to catching up on Reddit. Recently, I really haven't read the residency Reddit for about 6 months now, basically because I've been busy with boards and then raising a new baby. And I've been on paternity leave for the last couple of months, and it's been very, very busy. So I'm definitely looking forward to catching up on all the Reddit posts that I haven't been able to see for such a long time, and also making more videos soon for you guys as well. I'm also going to be planning to make more videos of like random things. I felt like a big reason I wasn't making videos is because I've kind of pigeonholed myself into, I should only make medical education videos and only making lectures and things like that. But I think the things that I want to make is a little bit more varied than that. Just, whatever my interest is at that time. And sure, it may make my channel a little bit less cohesive, but I don't know. I'll see what you guys think about it. I'll see if I enjoy it because I do like making other videos as well. And I hope you guys have been doing well. I'll see you guys in the next video, and peace.